Okay, so it is 11. I'm going to start. As people trickle in, I am putting the text code in the chat. It is the vid. Thanks to everyone for coming to Grill. I'm sure everybody is really tired of hearing about COVID after having been involved with it for the past 3 years, but today my grill is going to cover oral drugs for COVID-19, and we're going to be assessing whether or not these medications are science or more science fiction. Just before jumping in and starting, I would like to thank my content experts, Luke and Dan, for being available and helping me get this presentation to where it is today. As a brief disclosure, I do need to say I will be presenting information that's not yet based on current science, evidence, and or clinical reasoning, as none of these medications are technically FDA approved for the treatment of COVID-19. So this does technically fall with outside of the standard of care. So keep that in mind as we are going through evidence. By the end of this presentation, it's expected you'll be able to identify patients who are at high risk for developing severe COVID-19, evaluate the clinical utility of proposed oral COVID-19 treatment options, recommend appropriate therapies against COVID based on patient characteristics, and then additionally propose strategies for the management of drug interactions for patients who receive Paxlovid or nirmatrelvir with ritonavir. This is just a brief review of the outline of what we will cover today. We're going to start with just kind of a review about what COVID is itself, although most of us are very familiar. I know at this point in the pandemic, I don't need to spend a whole lot of time convincing you all that COVID has drastically changed the lives of many people around the world. But as we approach the 3-year anniversary of the first known case of COVID-19, we have seen just over 500 million people have tested positive for the disease, and over 6 million of those have passed away as a result. While Wisconsin is only accounts for a small number of those cases and deaths, it's really important to note that even our home state has been affected. In terms of what causes COVID, again, most of us are probably familiar. It's caused by the severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2, which is transmitted through respiratory droplets, and infection really occurs through direct infection of the upper and lower respiratory tract. The virus does get into the host cell via binding to the ACE2 receptor. And once the virus has entered the host cell, it begins to replicate, which really induces cellular death and injury. And as all of this is occurring, the host immune system kicks in to help eliminate those infected cells by recruiting various cells like macrophages, T cells, and monocytes. In some patients, however, this host immune response can be too robust and produces a cytokine storm, which typically overwhelms the host and leads to complications in severe COVID-19. Briefly discussing what the symptoms of COVID are, we all know things like cough, dyspnea, the classic loss of taste or smell. These things are things we're familiar with. And we also are familiar with some of those extrapulmonary complications of COVID. Few examples of those being CVAs, MI, myocarditis, acute organ failure, acute respiratory distress syndrome, and coagulopathies. It's not abundantly clear why some people have mild COVID and others end up with these extrapulmonary complications. However, there have been some studies that have identified risk factors for severe COVID-19. Based on those studies, the CDC has provided us or compiled a list of risk factors or comorbidities that have been associated with development of severe COVID-19. You can see those listed here on the slide, and they range variably. We can see patients who have lowered immune systems, such as cancer, HIV, patients who have had a transplant or use drugs that cause immunosuppression. We also see chronic diseases like chronic kidney, lung, liver disease, diabetes, heart conditions. Things like these have been associated with increased risk for severe COVID-19. There have also been studies done to assess that have shown having more than one of these risk factors does increase your risk of developing severe COVID-19 as well. Now that we're all on the same page about what COVID-19 is, it's time to talk about the failed oral COVID therapies that have been studied throughout the pandemic. For the sake of time, I'm only going to briefly cover these agents because the reality is that they didn't work, but it's still meaningful for us to discuss them. I'm going to start with hydroxychloroquine, which I remember as being one of the first drugs that we thought was going to solve the pandemic really early on, those first months in lockdown. The thought process behind hydroxychloroquine was really that it could inhibit viral fusion to the host cell and therefore prevent replication, essentially through increasing the endosomal pH and making it less likely that the virus was going to be able to enter the host cell. Someone is unmuted. If you could all make sure you're muted. Thank you. However, multiple randomized controlled trials in both hospitalized and non-hospitalized patients did find that there was no difference in mortality, the need for mechanical ventilation, or time to discharge, or even severity of COVID symptoms. So not super strong evidence to support the use of hydroxychloroquine. Second, we'll talk briefly about ivermectin. It was thought that ivermectin could suppress the host response to COVID-19 and theoretically reduce the incidence of cytokine storm that was associated with severe disease. But again, multiple randomized controlled trials did show that ivermectin didn't really change rates of hospitalization, time to symptom resolution, or again, need for mechanical ventilation. Next, briefly discussing colchicine. Proposed mechanism of action was really multifactorial and really essentially focused on the anti-inflammatory effects that we know colchicine does have. Again, multiple RCTs found no differences in mortality, time to discharge, need for mechanical ventilation, or hospitalization. And by this point, you're probably picking up on this theme that none of these treatments have really helped anything. And kind of one of the more recent theorized treatments for COVID-19 is fluvoxamine, which we all know as an SSRI used in the treatment of anxiety and depression. However, there have been some studies that it does provide some anti-inflammatory action, which was thought to, again, reduce cytokine production, prevent severe COVID-19. There haven't been a whole lot of studies on fluvoxamine, but the two strongest studies that do exist did show that there was no difference in hospitalization or mortality. So the verdict here is really these agents, science fiction, not really super strong candidates, not something that we should be recommending for treating COVID-19. Before we move on, as promised, I wanted you to kind of pay attention to what those risk factors for severe COVID-19 are. So if you could put in the chat what you think the answer to this question is. Which of the following patients is at high risk for progression to severe COVID-19? Is it A, a 22-year-old pregnant female with asthma, B, a 57-year-old male with a past medical history of renal transplant on tacrolimus, prednisone, and mycophenolate, C, a 76-year-old with a past medical history on CLL of CLL on venetoclax, or D, a 34-year-old male with a past medical history of HIV on Biktarvy. All right, I am seeing multiple E's. So this was an easy question. All of these patients are at high risk for developing COVID, and you can see kind of those risk factors for each of those patients highlighted on the slides. Okay. So now that we've discussed some COVID therapies that haven't worked, let's talk about one that has more promising data, starting with molnupiravir. Molnupiravir is a prodrug that's metabolized to a cytosine nucleoside analog, which is phosphorylated to a compound called NHCTP. This compound is incorporated into viral RNA via RNA polymerase, which ultimately causes an accumulation of errors that halts viral replication. Animal studies have suggested that molnupiravir has promise as a COVID antiviral medication, and then there are a handful of studies in humans that have also attempted to support this. One of those studies is the MOVE-IN trial, which was a phase 2 and 3 double-blind, placebo-controlled, randomized controlled trial that evaluated molnupiravir at 3 different doses, 200, 400, and 800 milligrams orally twice daily versus placebo in adult patients who were hospitalized with COVID-19. In this study, patients had to have an onset of COVID less than or equal to 10 days prior to randomization, and they wouldn't be included if they were critically ill, meaning patients who were in the ICU were not able to receive this therapy. In terms of outcomes that they were looking for in this trial, efficacy, they were looking at time to sustained recovery and then all-cause mortality at day 29. And then for safety, just the incidence of adverse drug events. All in all, the move-in trial was pretty small with only 304 patients being randomized at the end of the day. 226 of them were split relatively equally to the 3 different molnupiravir treatment arms and 78 of them to the placebo arm. Baseline characteristics were well matched across all treatment arms, and the majority of patients did have moderate to severe COVID, most presenting with COVID more than 5 days prior to randomization. And as you can see on the slide, they all had a mean age of around 57, just in general. When we look at the results for efficacy, these efficacy endpoints, researchers found that the median time to sustained recovery was 9 days in all treatment arms with no statistical difference between them. And they also found that there was no difference in the 29-day mortality recovery rates or all-cause mortality. So overall, in terms of efficacy in this study of hospitalized patients, it didn't really appear that molnupiravir really improved outcomes. Now at safety, at first glance, it appears that more patients in the placebo group reported any adverse drug event compared to the composite of all the molnupiravir treatment arms. However, this didn't really seem to be statistically significant. There also did not appear to be an adverse drug event, or a dose effect in terms of side effects with the molnupiravir treatment arms, the 200, 400 versus 800. Of those frequently reported side effects, the most common ones included GI disorders like nausea, vomiting, diarrhea, infection, and respiratory disorders, kind of combining those, a lot of COVID pneumonia, which kind of brings up one of the limitations of the study that even the researchers noted for themselves, that it was hard to decide if these adverse effects were related to the treatment regimen trial versus if they were more so due to being acutely infected with COVID-19. Another study involving molnupiravir is the Move Out trial. This was another phase 2/3 double-blind placebo-controlled randomized trial that compared molnupiravir at a dose of 800 milligrams twice daily to placebo in adult outpatients this time who presented with COVID-19. And in order to be included in this study, they needed to have onset of disease less than or equal to 5 days prior to randomization. And patients also had to be at high risk for progression to severe disease. This trial did identify patients who had active cancer, chronic kidney disease, COPD, obesity, serious heart conditions, diabetes, and an age greater than 60 as risk factors for progression to severe COVID-19, which is not all inclusive of the list that we now know from the CDC as those patients who are at high risk. Primary endpoints included the composite incidence of hospitalization or death at day 28 and incidence of adverse drug events for safety. Just over 1,400 patients were randomized, and the baseline characteristics between the 2 treatment arms were pretty well matched again. A total of 47.7% of participants had onset of signs and symptoms of COVID 3 days or less before randomization, and about 45% were classified as having moderate COVID-19. In terms of looking at the risk factors that made these patients eligible for inclusion in this study, most common of those were obesity, age greater than 60, and diabetes. So what did they find in the Move Out trial? During the interim analysis, which was about 50% of the expected enrollment had been randomized, rates of hospitalization and death at day 29 were 7.3% in the molnupiravir group versus 14.1% in the placebo group. This translates to a number needed to treat of 15, meaning that we would need to treat 15 patients with molnupiravir to prevent one hospitalization or death, which truthfully is not too bad. However, once the full analysis was completed with the total enrollment of 1,433 patients, that rate of hospitalization and death was similar in the molnupiravir group at 6.8%, but now compared to 9.7% in the placebo group, which translated to a number needed to treat of 34, which is much less impressive than a number needed to treat of 15. So ultimately, the interim analysis gave us a lot of hope for molnupiravir, but at the end of the day, this relative risk reduction of only about 30% doesn't really suggest that there's a lot of high efficacy or support or evidence that supports the use of molnupiravir for the treatment of COVID-19. Not really the silver bullet we were looking for. In terms of safety, looking at adverse drug events, incidence was similar between the molnupiravir group and placebo group at rates of 30.4% and 33% respectively. Investigators in this trial specifically evaluated whether or not they considered these adverse events that were reported as being caused by the trial regimen versus just having COVID. And they reported that the true incidence of ADA or adverse drug events attributed to the trial regimen was 8 versus 8.4% in the molnupiravir and then placebo groups respectively. Of those adverse drug events that were considered to be due to the treatment regimen in the trial, the most common or frequently reported ones were diarrhea, nausea, and dizziness, which occurred in greater than, I believe, 2% or 1% of patients. So based on these and other studies, the FDA did issue an emergency use authorization for molnupiravir in December of 2021. There have been some minor updates to the EUA, with the most recent update having been published in March of this year. While molnupiravir is not approved for the treatment of COVID-19, the FDA, through this EUA, has authorized its use in outpatient adult patients with mild to moderate COVID-19 who are at high risk of progression due to severe disease, for whom alternative COVID treatments are not accessible or clinically appropriate. So this last little bullet point here is going to be something that's really important for you to remember going forward as we kind of summarize at the end of the presentation when things are appropriate to use versus not. So kind of sticking with our theme of science versus science fiction, there is some science to support that molnupiravir may be mildly effective at preventing severe COVID-19, but again, the evidence is not super strong to support its use if there are potentially better alternatives available. Knowing that we could use molnupiravir though, you are likely having the question of, if I choose to use it, how should it be used and what should I know? So first, we'll discuss dosing. As previously mentioned, molnupiravir was studied at a dose of 800 milligrams PO twice daily for a total duration of 5 days, which is what the FDA suggests based on their emergency use authorization. It does not need to be dose adjusted for renal or hepatic dysfunction, which makes it attractive to us as pharmacists because that kind of tells us maybe the kinetics suggest there's not a whole lot going on. Of note, patients must be started on therapy within 5 days of symptom onset. And if they miss a dose, they can take it as long as they remember within 10 hours. If not, they should just skip it and go to the next dose at the normally scheduled time, instructing patients not to double up on those doses. Another interesting thing that's recommended in the emergency use authorization is that if a patient is hospitalized at any time during their treatment, it's reasonable to continue per the provider's discretion. Knowing kind of with our health system, it's not something we technically have on formulary, so this would need to be a patient's own medication if that were to happen here. Kind of as I alluded to on the previous slide, looking at the kinetics of molnupiravir, it's not hepatically or renally cleared, which again makes sense why we don't need to renally or hepatically dose adjust. Other important things for us to know as pharmacists, it does not appear to be a substrate inducer or inhibitor of any CYP enzymes, P-glycoprotein, or BCRP. And with that all being said, seems unlikely that molnupiravir has any drug interactions. There have not been any reported thus far, which makes it very attractive from a pharmacist standpoint. However, with the evidence not being great, that's not super positive. However, that doesn't mean it's an absolutely safe drug. In animal studies, it was found that molnupiravir can cause fetal harm, and for that reason, it's not particularly recommended in pregnant women. However, the EUA does specify that if there's a risk-benefit discussion with the provider and the patient, that it could be reasonable, especially knowing that pregnancy itself is a risk factor for the development of severe COVID-19. For this reason, we also need to be counseling our patients that effective contraception needs to be used during treatment and also post-treatment. So for females, they have completed some studies that have shown that 4 days of effective contraception post-treatment should be enough. However, there's still ongoing trials for males, and the recommendation is that males need to use contraception for 3 months post-treatment if they have a partner of childbearing capabilities. Other warnings and precautions with molnupiravir include hypersensitivity. Anaphylaxis has been reported in a small number of cases, which is just a risk for every medication. And then there have also been reports of bone and cartilage toxicity, especially from these animal trials, which is why molnupiravir is not recommended in pediatric patients or patients less than 18 years of age. All right, so before we move on, we are going to do our next assessment question here. Again, if you want to put your answer in the chat. For which of the following patients would molnupiravir be least appropriate? Our 22-year-old pregnant female with asthma, our 57-year-old with a renal transplant on immunosuppression, our patient with CLL on venetoclax, or our patient with HIV on Biktarvy, or all of the above. All right, maybe I made these questions too easy. I see in the chat many A's, and you're absolutely correct. We would ideally like to avoid molnupiravir in our pregnant patient just because, again, there is risk of fetal toxicity, and knowing that the evidence for molnupiravir is not super strong, seems like risk might outweigh benefit. So moving on from the mild disappointment that was molnupiravir, we're now going to discuss the combination product nirmatrelvir-ritonavir. And for the remainder of the presentation, I will likely be referring to this combination as its trade name Paxlovid, just for convenience, as it is a mouthful. So Paxlovid is a combination product of nirmatrelvir and ritonavir. The nirmatrelvir is the actual active agent against COVID-19. It's a peptidomimetic inhibitor of the COVID main protease, Mpro, which is essential for processing polyprotein precursors, which when you inhibit or we inhibit that protease effectively, it prevents viral replication. The ritonavir component does not have any actual activity against the COVID virus itself. However, it functions to boost the concentrations of nirmatrelvir, similarly to how we use ritonavir in our HIV patients. I'm going to discuss two Paxlovid trials, starting with this one, the EPIC-SR trial. This was a phase 2-3 double-blind randomized controlled trial that assessed Paxlovid versus placebo in adult outpatients with COVID-19. These patients had to present with symptoms of COVID or have a positive COVID test within 5 days prior to randomization. Of note, the SR portion of this study means standard risk. So only patients who were standard or low risk for progression to COVID-19. So most of us young, healthy adults, this is that population that was being studied here. So patients who had any of those risk factors that we've previously talked about in other trials and in the beginning of this presentation were excluded. In terms of endpoints that this trial looked at, very similar to others that we've talked about. In terms of efficacy, they were looking for time to symptom resolution, and then incidence of hospital or death, and then our fallback safety monitoring for incidence of adverse drug events. This trial is actually still ongoing, and there are minimal results that are available. But what we see here is actually from a press release from Pfizer, which is the manufacturer of Paxlovid, on one of the primary endpoints of hospitalization and death. They didn't really have any other information available in terms of time to symptom resolution, which is interesting because that was actually their primary endpoint. But the interim analysis, which included 45% of infected enrollment, found a rate of hospitalization and death of 0.6% in the Paxlovid group versus 2.4% in the placebo group, which translated to a number needed to treat of 55. And then the follow-on analysis, which included 80% of expected enrollment, had similar findings of 0.7% incidence in the Paxlovid group versus 2.4% in the placebo group, translating to a number needed to treat of 61. While this was statistically significant with a p-value of 0.05, when we kind of interpret these results based on the number needed to treat, again, reframing that as 61 patients would need to get Paxlovid versus placebo to prevent one hospitalization or death, doesn't really support its use necessarily in this population, especially when we are considering resource utilization. And as we'll kind of get into next, thinking about what these results might be like for somebody who's at high risk for severe COVID. Which leads us very well into the EPIC-HR trial. So as you might have guessed, HR is standing for high risk. So this was a phase 3, again, double-blind, placebo-controlled, randomized controlled trial, looking at Paxlovid versus placebo in adult patients with COVID-19. Again, looking at patients in the outpatient setting. Excuse me. Looking at patients in the outpatient setting, similar inclusion criteria, meaning that they needed to have symptoms of COVID less than or equal to 5 days prior to randomization, and then being high risk for progression, which this trial defined as having at least one of the following characteristics. So age greater than 60, obesity, meaning BMI greater than 25, smoking, immunosuppressive disease, prolonged iatrogenic immunosuppression, chronic lung, kidney, or cardiovascular disease, sickle cell disease, hypertension, diabetes, cancer, neurodevelopmental disorders, medically complex conditions, and medical-related technological independence. So not exactly consistent with what the CDC has reported for us, but very similar. Primary efficacy endpoint studied was, again, hospitalization and death, and then incidence of adverse drug events evaluated for safety. So it's probably one of the more robust trials that we have for treatments against COVID-19, at least in this oral setting. They had randomized 2,246 patients with 1,120 receiving Paxlovid and 1,126 receiving placebo. Baseline characteristics were pretty well matched between these groups with a median age of 46. Of note, most of these patients, a whole 71.5% of them were white, so that does limit the generalizability of the results that we will talk about. In terms of the pre-specified conditions that allowed these patients to be included in the trial, the most common of those risk factors was BMI greater than 25 in 80.5% of patients, smoking in 39% of patients, and hypertension in 32.9% of patients, with the majority of them, a total of 61%, having more than 2 or more coexisting conditions. In the interim analysis, they found that patients who were treated with Paxlovid within 3 days of symptom onset had significantly lower rates of hospitalization compared to those who had received placebo. And this remained true with the final analysis, and they further looked into the data for treatment within 5 days, which is what I've presented here on the slide. They found that 0.77% of patients in the Paxlovid group were hospitalized or dead within 28 days at randomization, compared to 6.31% of patients in the placebo group, which translates to a number needed to treat of 19. So again, not super impressive, but not super disappointing either. This was statistically significant, and reframing, kind of, we can frame these results in many different ways. They had reported an 88% relative risk reduction for hospitalization and death. But again, number needed to treat of 19 is reasonable, and certainly much better than what we saw with molnupiravir. Looking at safety data, incidence of adverse events was similar in both treatment and placebo arms at 22.6% versus 23.9% respectively. Most common adverse drug events reported included dyschezia, diarrhea, fibrin D dimer increase, LFT elevation, headache, nausea, vomiting. But again, hard for us to discern if all of these adverse drug events are related to the study regimen versus having COVID itself, especially thinking with that fibrin D dimer elevation. Hard to say if that's really the drug versus COVID based on what we know about the disease of COVID. Given the results of these and other trials, the FDA issued an emergency use authorization for Paxlovid for the treatment of COVID in December of 2021. For the sake of time, I didn't discuss the ongoing trials of Paxlovid in children. However, it is worth noting that in interim analyses, there is similar efficacy in children aged 12 to 18, which is why this population is included in the EUA criteria. So kind of further defining it, again, this is not FDA approved, but Paxlovid is authorized in high-risk adult or pediatric patients who are at least 12 years old and at least 40 kilos for the treatment of mild to moderate COVID-19. And again, they have to be high risk. So the verdict, there's some pretty good science to suggest that Paxlovid is a reasonable treatment option for COVID-19 in our high-risk patient population. Moving on to what do you need to know as a pharmacist? Spoiler alert, it's kind of a lot. Starting off with the simple thing, dosing. Nirmatrelvir and ritonavir, this combination medication, it comes as a dose pack. So it originally when this medication came out, it came as a dose pack with 2 separate 150 milligram nirmatrelvir tablets and then a ritonavir 100 milligram tablet, which was great for our patients with normal renal function because they just took 2 tablets twice a day of the nirmatrelvir and then the ritonavir twice a day for 5 days. However, with patients who have renal dysfunction, they were only able to take 1 tablet of the nirmatrelvir with the 1 tablet of ritonavir, so we needed a dose reduction. And more specifically, patients' renal dysfunction was defined as having an eGFR less than 60 but greater than 30. This is not so much a weird problem anymore, as recently, I believe it was last week, there is a new dose pack specifically for the renally dose-adjusted dose for Paxlovid. However, previously, it was kind of a hard counseling point for pharmacists trying to explain to patients that they should not take one of the nirmatrelvir pills, but take one of them, which is really hard to explain to the patient. But again, no longer a problem. We have 2 different dose packs, which is great. Other things to keep in mind that's important when we think about dosing with nirmatrelvir, it's not recommended in patients who have severe hepatic or renal dysfunction. So renal dysfunction being severe as defined as eGFR less than 30, as it's not been adequately studied. And again, similar to molnupiravir, we have to initiate this within 5 days of symptom onset, just based on what was studied in our clinical trials. And we would instruct patients to take it for a total of 5 days. Patients can take missed doses as long as they remember within 8 hours. Again, they should not double up if they miss a dose. And similar to molnupiravir, the FDA did suggest that if a patient was hospitalized at any point in the treatment with Paxlovid, it could be continued per provider discretion. Moving into the pharmacokinetics, again, as you may have guessed based on dosing recommendations, there are some considerations we have to have here. Nirmatrelvir is eliminated renally, which is why we do need to renally dose adjust, and it is a substrate of CYP3A4, a major substrate of CYP3A4, as well as P-glycoprotein. Ritonavir, as likely many of us are familiar with, is hepatically eliminated, and it is a substrate and also an inhibitor of CYP3A4 and CYP2D6. But with ritonavir, that's not all. This slide is meant to overwhelm you to kind of give you an appreciation of how ritonavir can really throw a wrench in our drug therapy plans. It's an inhibitor, as I had said, a major inhibitor of CYP3A4, which most of us know, but also CYP2D6, MRP2, P-glycoprotein, ABCB1, and beyond just being an inhibitor of multiple CYP enzymes, it's also an inducer of multiple CYP enzymes. So we see CYP1A2, CYP2B6, CYP2C19, CYP2C9, and then also UGT1A1. So the moral of the story with ritonavir is that it's the cause of many, many drug interactions, and it's something that we need to keep in the back of our minds as pharmacists when we are hopefully involved in the prescribing of Paxlovid. So to overwhelm you even more, we're just going to kind of look at some suggested lists of medications that we need to consider when we're dosing people with Paxlovid, knowing this drug interaction with ritonavir. This is not an inclusive list. This is actually a list provided by, there's a clinical practice guideline group that was published by Canada recently. And this is just kind of a screenshot of some of the medications that they have identified that we need to be high alert on, or kind of have a high alert understanding of when we're dispensing COVID or Paxlovid to our patients. A little bit more information on kind of when we're thinking about CYP3A4 inhibition and how do we manage these drug interactions. A few studies have shown, kinetic studies have shown that the time to maximum enzyme inhibition is about 48 hours or 2 days, and time to resolution or kind of resolution of that CYP3A4 inhibition specifically is anywhere from 48 to 120 hours, so 2 to 5 days. This kind of provides visually what that disappearance rate of CYP3A4 inhibition, specifically with ritonavir, actually is. And as you can see, by day 5, for patients in most age groups, we have almost complete resolution of enzyme inhibition. But if we look at our older patients, it really takes longer versus our younger patients. You know, we could get to 87% or 80% of enzyme resolution by day 2. Again, just considerations for us to have when we're thinking about what should we do with some of these interacting medications if I have a patient who really needs Paxlovid. There are some guidelines for management strategies for these drug interactions. In some scenarios, we would say that Paxlovid is really contraindicated, and the majority of times where we would consider that is if stopping the drug would not really mitigate the interaction, meaning we have drugs with narrow therapeutic indexes, drugs that have prolonged half-lives where if we stop the drug for 5 or 7 days, it's not really actually going to do anything. That interaction is still going to cause a problem. We also have medications where we consider not co-administering, meaning we could potentially hold and restart the offending medication or the interaction medication after completion of therapy. And based on kind of the study that I had previously presented, the most common management strategy there is holding the medication during therapy and then resuming 2 days after, knowing that for most patients, enzyme and resolution of that inhibition will happen around that 2-day mark. There are also medications that we maybe should just be more cautious of, but not necessarily worry a whole lot about. In terms of we could potentially modify therapy. This means that we could potentially decrease the doses of medications and feel during treatment and for 2 days after and feel confident that that's well managed. And then there are other medications that theoretically could interact with Paxlovid, but are not likely to be clinically relevant. A few examples of those, just again, non-inclusive list, but things that maybe you would more frequently see. Things we definitely wouldn't want to use: amiodarone, lorazepam, ranolazine, venetoclax. These medications all have incredibly long half-lives and also have pretty narrow therapeutic indexes. Co-administering these with Paxlovid could result in very dangerous scenarios. Medications where we should definitely pause and consider holding medications, things like colchicine, blood thinners like Xarelto, statin medications. These are very frequent medications where we would instruct the patient to hold and then resume 2 days after completion of therapy. You'll notice that tacrolimus is also listed as one of these potential medications. It's not preferred, and if we could do therapeutic drug monitoring for all of those days that the patient was off of the medication, that would be ideal. Maybe not the easiest thing to do, but technically, theoretically, it is possible. Medications that we could consider just decreasing the dose of while the patient is on Paxlovid would be things like amlodipine. This has atorvastatin listed, buspirone, nifedipine, calcium channel blockers just in general. And then other medications that we've seen probably are not clinically significant, things like citalopram, fluoxetine, does not appear to be clinically significant. What warnings and precautions besides having significant drug interactions do you have to worry about with Paxlovid? Again, potential for anaphylaxis. Ritonavir itself is also associated with TEN and Stevens-Johnson syndrome, so being on the lookout for those things. There have been reported events where patients have had elevations in LFTs, clinical hepatitis, and jaundice. So again, looking out for that. And there's also some concern for HIV resistance in patients who have undiagnosed HIV or uncontrolled HIV. However, the FDA does still suggest the use of Paxlovid even in patients with HIV without any changes. All right, so our next assessment question here. For which of the following patients would Paxlovid be contraindicated? So our 22-year-old pregnant female, our friend with a renal transplant on immunosuppression, our patient with CLL on venetoclax, our patient with HIV on Biktarvy, or all of the above. Yeah, perfect. So as I had previously hinted at on a previous slide, venetoclax has an incredibly long half-life of about 26 hours. So we really would prefer not to use Paxlovid in this scenario, as it would likely be more harm than benefit to the patient. Now, you're probably thinking, this is all great and well, but we have a lot of changes in which variants are most common. Especially right now, we're thinking more about the Omicron subvariant BA2, and are these agents going to work? We know that a lot of our other treatment options, like, for example, sotrovimab, our monoclonal antibodies in general, are affected by what subvariant is most dominant at the time. And the positive news is that these oral antiviral therapies are expected, based on in vitro antiviral studies, to still have some activity against subvariants. And again, there's not a whole lot of actual evidence out there, but based on the few antiviral studies that we do have, they are expected to continue to have efficacy even with variants kind of coming up. It's really definitely a consideration that we need to have as kind of things progress, as we see new variants. We'll have to continue doing studies and seeing if these medications continue to work. But again, as of right now, we are pretty confident that they will continue to be reasonable treatment options, which is something that we can't always say for our monoclonal antibodies, which makes these oral medications that much more attractive. And kind of the last thing to kind of clean up and summarize here is, how should we actually use these agents? The NIH does have some very detailed treatment guidelines for COVID-19, and in outpatients, Paxlovid is actually a first-line medication for the treatment of COVID-19, followed by remdesivir. A lot of times, the feasibility of Paxlovid is a lot greater than remdesivir, as we don't have to get a patient in an infusion chair to come get remdesivir for 3 days. So those are considerations. However, if a patient maybe has one of those drugs that's contraindicated with Paxlovid, we would consider choosing remdesivir over Paxlovid. And then molnupiravir is potentially appropriate, but really only as an alternative therapy if Paxlovid or remdesivir is not feasible or clinically appropriate for the patient. Kind of the last consideration is knowing that there's not a huge supply of these medications out there. Who do we prioritize? And the way that we have done that, based on the NIH treatment recommendations, they have developed different tiers based on patient risk factors. We've considered our immunocompromised patients, those who probably haven't developed an adequate response to the COVID vaccine, or having previous SARS-CoV-2 infections, as being our most high-risk individuals, as well as those who are unvaccinated and have risk factors for disease, severe disease. So we would prioritize those patients, and then you can refer to the NIH treatment guidelines to kind of further delineate who would be next on the line while we're working through kind of demand and supply issues. So in summary, there are only a few oral treatments against COVID-19 that have proven to be at least moderately useful. Molnupiravir and Paxlovid are the only oral COVID treatments that have reasonable evidence for use, with Paxlovid being the first-line outpatient treatment. However, use should really be closely monitored by providers due to potential for major drug interactions, and that's probably a huge area where pharmacists can also be leveraged. So if you took anything away from this presentation, number one, it should be we need to continually assess the activity of these antiviral therapies against COVID, as this may change as new variants arise. Molnupiravir is not recommended in pregnant women, but can be considered second line if alternatives aren't available, just in general. And patients at high risk for severe COVID-19 should get Paxlovid with close monitoring and management of drug interactions. With that, I thank you all for your attention, and I will answer any questions. Okay, so first question I have is from Cam. How do we obtain Paxlovid? What does our stock look like in outpatient? So that's a good question that I don't 100% know the answer to. I know that we do have a small supply. I don't know how much we get, but we do, similar to kind of what our monoclonal antibody distribution is like, patients are able to kind of submit themselves for review for eligibility. And then we have a pharmacist who goes through and they kind of get randomized whether or not they're eligible. And there's like a randomization process to decide if we can offer a patient Paxlovid, again, prioritizing our tier 1 patients. I'm sorry, I do not know the answer to what our actual stock looks like. And then Hannah's question is, what is your assessment of the risk for development of antiviral resistance with mono antiviral therapy? Hannah, can I just clarify, are you asking for just in general for treatment of COVID, or like if we only have one antiviral available, what's my assessment of the development of resistance for COVID, or are you thinking specifically for patients who have HIV?
No, specifically for COVID, so using molnupiravir or Paxlovid.
Yeah, that's a great question. I guess it's not something that I have actually considered myself. I think it's certainly reasonable to be concerned about that. I guess I don't know that I have a strong assessment right now. I don't know if either of my content experts do either.
Too soon to know also.
Yes.
Because these aren't even fully FDA approved. Take some time to identify what the resistance will be. Mechanistically, again, it seems like it would be fine, but then it also does come down to the variants and how those mutate versus even drug resistance within the same subvariant population.
Were people able to hear Dan? Hard to hear. Okay.
Thanks, Julie. I don't think there's good data on the resistance. It's hard to know whether resistance will come within the subvariant populations also, or whether it'll just be a mutation to create a new subvariant or variant of COVID that will then be resistant to these agents. So I think it's one of those things where like we'll see how it works, and we'll see as COVID continues to grow and mutate.
Thanks, guys.
All right. Well, if there are not any other questions, thanks to all who attended, and we'll see you next week.